slow fluctuation that the venous malformation occupy 2/3 of what will be seen at the OP. So most of the time these lesions are seen nicely there with a bluish type of thing, and it can be anywhere in the head and neck region. It can come just like a cosmetic area around the eyes, even disturb the eye function, or it just comes with the bleeding in the mouth. When you have a poor dental, this is very important to make sure that you work with the ENT and the dentist when you start to treat the lesion in the region of the mucosa area. So again, the fibroid is there, it can be seen in the orbit. So we know already this type of genetic aspect that I showed you in the diagram. So it comes to the treatment later if you cannot do the regular type of treatment. So the slides from the group that coming to publish in the year 2008 that we have a lot of location of the venous malformation all over the body. This is classic. They have the same thing, which is elevated. The diagnosis has just analysis of all the venous malformation all over the body, the high-tech mutation. Clinical presentation, as you see, most of them are just cosmetic. It can be bleeding, it can be painful if there is a kind of infection or the ulcerative type of thing. So histopathology, you know that we are dealing with this plastic post-capillary thin wall vascular channel, and that this plastic venous channel usually connect with adjacent. So ultrasound finding out, I use mostly ultrasound guided during my treatment. It's rare to go for the CT or MR guided. Usually it is reachable. You can just bring the machine. You can do the treatment for percutaneous thing as the OP type of thing. MR finding, that we are there with all the classic signal between T1 weighted and T2 weighted, and we can check the hemorrhage on high protein content, which is fluid-free things. Types. People try to differentiate into types. For example, type 1, 2, 3, 4 related to the outlet. So I'm not sure it's really matter. Usually we try the very small channel outlet if it needed, and you can demonstrate it's just good to block the outlet during your treatment. So we used to start the treatment with many types of the sclerotherapy, including the very high potential absolute alcohol by that time. And we sometimes we work with the surgeon to do this treatment. Talk a little bit about bleomycin. I think bleomycin is now widely used. Everybody knows that it's mostly very safe, and what we do now is we are explaining the patient after making sure that you make a correct diagnosis. You tell that the lifetime accumulation of the medication is 300 milligrams. So if you are not reaching that dose, most of the time, if you can make only 15 milligram per session, you are not worrying much about the accumulation dose in the lifetime. It works also with the lymphatic malformation. So we work together with the team also to try to see this, and we believe that the macrocystic work much more and than the microcystic. But the larger one of the lymphatic malformation, most of the time you need a combined treatment, especially when you have the airway obstruction in the young baby. Usually you need to add some medication, not only the sclerotherapy. Lymphatic malformation usually classic, you see the evolution of the size, and you see classic the ultrasound finding that you can mostly puncture, draining out the content, or even in microcystic, you just make a little by little injection in the dense area of the malformation, and usually it works also. Ultrasound guided will be seen there, rarely MR guided. Okay. So the airway is something that you need to worry sometimes. The intubation or even the tracheostomy prevention need to be done in all of these treatment to prevent some swelling related to the treatment. I explained already about the efficacy of the macrocystic more than microcystic, but it works. Okay, so we also talk about musculature, but usually the action is to decrease the vascular endothelial growth factor, which is the key regulation of this pathology. In the very good experience, at least newborn 3 kilos with large macrocystic neck lymphatic malformation, the treatment there was a 2 treatment of this sclerotherapy that by the team using this escape form of ethanol and doxycycline that is well used in the US, I think, by that time, and the express in this much improvement or surviving condition of the airways and the lesion decrease in size. So there is this sclerotherapy response. Usually the macrocystic have a 90 to 100% response, while the microcystic has a little bit 50% response. So we know that we can do in every single location. When it's becoming around the orbit, we always work with the ophthalmologist. You can notice that most of the time we don't inject through the conjunctiva. They still love to go from the skin and try to push the probe away from the direction of the needle. So the bleomycin used to be working with all this effect many years ago, and then the response piece was found, and then it seemed to be very few chance of have the pulmonary fibrosis related to the lifetime accumulation of more than 300 milligrams, which, imagine that 15 milligrams per session, you need to do 20 sessions, which is not happening. My maximum session is probably 3 sessions. Within every session should be not more frequent than 6 months once. But usually I wait until 1.5 to 2 years to start the second session. This is example of the nurse working with us with this condition that she believes that she needs to be treated. And we try to see the real effect of the function if we can decrease from the before and after treatment picture. Before and after treatment picture. This is mostly once injection. Differential diagnosis, we were having this girl having a kind of, examination, a little bit bluish color, and it's a little bit bulging when you bend down. And finally, I found that there is a kind of connection to the venous drainage upstream. So we try to make a decision to go with angiogram, and the angiogram actually show us this connection and a kind of venous aneurysm of the extramedullary vein. So it means that for me, if it's not disturbing anything in life, I will not try to go and treat either way. So we are keeping follow up her with just her external jugular vein dilatation. Eyelid can be, 3 to 6 months follow-up. The dose starting from 5 to 15 milligrams depends on how much you can drain. If you can hardly drain any blood out, usually with a small space, you make either 5 or 10 milligrams concentration rather than use the full 15 milligrams in a small area like this. And I told you that we have a lot of variation in this group that we found. In oral cavity, this boy is having a big lesion over there, and sometimes it's disturbed. Most of the time, it's chewing things. He always chew this lesion and have a bleeding. So we can do as many needles as possible to try to, do this aggressive treatment to the lesion over there. And finally, the boy is getting better, and this lady is also, getting better from her bleeding frequently, and we still keep follow up both of them. So mucosal buccal lesion can be treated by us. Usually, if it's deeper than anterior 1/3 of the tongue, I will need ENT to come inside the room with me and try to put a kind of scope helping us to do the injection. So result, this is a nice example that the team in our same university treated. So she is treating this multiple sites of venous malformation sclerotherapy, and from the very bulging one to this one is a rheomycin totally 3 session. So it's very acceptable result. The patient starts smiling. And in this group of 5 years old girl that she has also the malformation around the lip and sadly drooping figure. And after this, the team was doing quite a frequent session, but each session is not too much. It's 10 milligrams a session, and have a good result. Ourselves, we did the microcystic injection at the time, and it seems to be not bad result in the follow-up 3 to 6 months also. Macrocystic lesion is getting much better with the rheomycin. The eye is, as I told you, we try to work with ophthalmologists to go hook into the lesion, and this is how we use both ultrasound and fluoroscopy. If you were able to hook there, you know that you get a drainage, which usually become a venous plus. If it is veno-lymphatic, you can find a little bit diluted content out. In a limited space, you should drain, not 10 cc, but as much volume to drain out before you put into the rheomycin mixture. And then to test sometimes at the beginning, if we are not sure that we are totally in the space, we put a little contrast to make sure that you are good in the location of the pocket, and you start to push your rheomycin dilution, and it will dilute the contrast out. So you are now, using your rheomycin to make sure that you are still keeping the space. So in that time, you may have the follow-up of CT still located your lesion. For example, in the orbit, this is before and after. We did, I think, 2 sessions of this percutaneous rheomycin, and the patient don't need to go for any surgery. The optic nerve is coming back to normal, and this is the long-term follow-up, as I told you, 8 years and 12 years. She developed the dural sinus, the oculodural malformation. We were able to treat the oculodural malformation by the course mostly, and this is her now. Another patient, you see the chemosis exophthalmos is seen, and you have the blurring of the ipsilateral side, That means the lesion is already start to compress the optic nerve. By that time, we were able to do the same treatment, and we used the angle that we can work with guiding of the ophthalmologists. We work together, and mostly we use the CR. We have the ultrasound nearby, but mostly we do it there. And this is the same thing. We put a little contrast. We make sure that direction of the needle is all the way through the lesion. And this is before and after 2 sessions, which they're still there. I mean, it's a little thing over there, but she's free from the optic nerve compression, and it's quite amazing that after 10 years follow-up, it's very stable. She's having the normal eye, and she just met me a week ago for the 12 years follow-up. So they are very complex lesion. Look at the eye and almost bleeding from the exophthalmos eye, and we were able to hook into to try to inject these things, and then we try to get the content out. We were able to do that, and we really need a combination of the ophthalmologists, neuro-ophthalmologists, to try to help us in case we need to combine this type of surgery. The complex one is within the so-called venous lymphatic malformation. You have the fast venous drainage out. You may involve in a type 3, 4, and if you have something related in the brain. So we were having this patient, and we thought, no, we're gonna do the treatment. And the very first session, I will usually do the angiogram because I just want to see the associated vascularization. And we were punctured as usual, and there is a huge bleeding outside from the needle. And I was injecting the contrast to test what's going on, and it turns out that this pocket connected partly with the common sinus, so it's a kind of I need to discontinue the junction between these to make the pocket isolated and not draining outside into the common sinus, but all the real medicine going to the common sinus. So I put some glue to disconnect this pocket, and then we were able to have the non-connected pocket to be able to put the treatment. I put just disconnect the part. So there are things that can be from a standard treatment, and we published this with the ophthalmologist for the orbital lymphatic venous malformation with concomitant spontaneous orbital arteriovenous fistula. So we were having this. Again, we didn't notice it why we have a slightly intense enhancement within the lesion. By the time we ignore the finding that we should not ignore. And again, luckily we were doing the angiogram, and we were finding this, and we know that if we puncture this lesion, which there is very large associated with the shunt at the top of the orbital apex, it's going to be bad. So we were able to try to do a transvenous embolization of the shunt, and then we were able to do the direct puncture. We inject this is course and treatment of the lesion behind, and this is the lesion at the orbital level. And after that, we need a combination of the surgery. You see the scar of the surgery over there, and the team is doing good job. We were having not bad results. So yeah, variation that sometimes we need to look at this man. There's a very bad lesion over there, and we were able to see that this is throughout fast lesion and the intralesional contrast testing. So we were sure that there is no connection there. We were able to do whatever we tried to decrease the shunt. We were not bad in decrease 2 times bleomycin session, and shrink all of these. And right now, from here, we're not able, or not bad. The ophthalmologists try to do some surgery to be able to save the cornea from directly exposed to the air, and so we can still keep follow up the man in a much better condition. Is there any problem? Yes. If the sclerotherapy in this child start with the alcohol, I told you that 15 years ago we were using alcohol injection, and massive swelling can occur with alcohol for sure of that. And when later on we were not putting any more alcohol, we used another additional bleomycin session to make the result much better. Swelling is the thing. Skin tattooing is reported. We have few cases, and this hyperpigmentation is not necessarily occur at the percutaneous location that we did. It can happen any place in the body with tight plaster or rubber band or whatever the contact. It can it's a kind of systemic reaction to the bleomycin, and you need to tell, especially in a young lady, to happen that she may have this what we call skin tattooing. Actually, it's a hyperpigmentation that can occur, and it will result in few years time, at least many months after that, and it can happen in any way. So we need to prepare with the ophthalmologist to use something not tight. When we do this treatment, for example, we use a loose gauze or band or things to loose one. Try not to fix with something very tight to stimulate the hyperpigmentation. We have one very complex case, especially the airway, the tongue. This is before that is large lesion, so the team went with the absolute external injection, and you can see that the swelling, putting the local structure, even the preventive tracheostomy was done. Is putting the chin, the structure, and the tongue out. And it's even getting the tongue out. It already discussed with the ENT whether you need to do a glossectomy, a partly glossectomy to get the situation better. And finally, they were able to do some follow-up, and luckily the swelling decreased on time enough to get this result. But be careful for the swelling if you use still the sclerotherapy that can create more symptoms. Talking a little bit about the sirolimus that we start also if we were not able to treat by other means, and it's very infiltrating type of pattern of slow flow vascular malformation. We know that we are talking about this inhibitor side that we know it used to be, cannot mention, it used to be antifungal, and even it used to be part of the cancer treatment in old times. But right now, you are pushing from approximately 1.5 to 2 milligrams per square meter per day. So it is going to come out with this kind of milligrams. So there are very few reported of the bad side of sirolimus. So this is our own case. We were having the child. It's not possible to do just the bleomycin alone. So we start discussing with the pediatric teams to start with this dose, and this is in 2.5 months follow-up that the massive lesion shrink nicely. So there are high response rate for the slow flow venous malformation, but there are some still things to be careful. They report that you can treat in the younger patient and no other treatment before, but it is very difficult to find a group. So usually it is not response much to other treatment that we start is. I think we are gathering around 10 cases now. I hope that in a few years' time we can understand more what's going on with this group of patients that we need to treat, and mostly in younger age group it's only the case with airway obstruction that we try. And they report that even in the very bad condition of the vascular lesion, for example, in this extremity, come back to 2 years later with that long-term use of this VENOUS. Again, probably this type of medication is mechanism that the blockage activities of the mammalian target for rapamycin, and it's regulate its protein kinase that regulates growth factor. So most of the effectiveness are there, but in some of the metabolic arteriovenous malformation, we try whether it's going to help in some special condition, and as you know that it seems not to shrink thing. So nowadays what we know about this VENOUS, it seems to supportive rather than curative action for the lesion, and very few side effects, including the oral mucositis and this group of things. So in conclusion, I think cerebral vascular malformation, we have some roles, so-called endovascular treatment, which is mainly the percutaneous intralesional injection, which we can do in many places all around the head and neck region, especially the one that produce symptoms. So there are other type of treatment, including the new pathway inhibitors. We always work with the dentist, with the ENT, with the eye ophthalmologist who knows a lot of things about vascular disease. And finally, we sometimes need to talk with the plastic reconstruction surgeon. Thank you for your attention.